Welcome back to this week's episode of Hormones, Metabolism, and You. I'm your host, Dr. Cassie Smith. I'm a functional endocrinologist based out of Oklahoma City. This week, I'm going to do something a little different with you guys. It's going to relate back to hormones, but this week I have Dr. Jordan Robertson. She is a physician who teaches physicians, looks at research, and asks questions about standards of care. Welcome back to this week's episode of Back to the Basics. Thank you for joining me today. Today we're going to do something a little different, but we're going to kind of bring it back and talk about hormones. I have Dr. Robertson, and she kind of specializes in teaching physicians and is really good with teaching people knowledgeable things and just kind of going back and looking at like gaps in standards of care. And she does it from a functional medicine standpoint, which is nice because a lot of functional medicine providers will tell you it's really hard to go and find information. A lot of the information that physicians use are in things like up to date, where they look at traditional medicine type stuff, but not necessarily functional medicine. And so she has created a platform to help providers with this. And so she's going to kind of talk to us about some of the gaps that we have in traditional medicine and standards of care and how we can kind of extrapolate that into the functional medicine space with hormones, which I think will be very beneficial. And then we might also bring in some GLP-1. We'll talk about muscle mass and some different things that you guys like. So she's on a mission to elevate integrative and naturopathic medicine to the standards of care that conventional medicine practices while simultaneously involving the unpaid research, labor crisis, and naturopathic doctors. With a 15-year career in facilitation, research inquiry, and critical appraisal at Macalester University, Jordan has taught thousands of students how to be better communicators, work in teams and research nutrition, integrative care, medicine, and space medicine. That last one while co-facilitating a course with NASA, which is pretty cool. Dr. Jordan is the founder of The Confident Clinician, a database, clinical decision-making tool, and home for over 700 full-time members, 60 fellows in her leadership program, and over 5,000 clinical subscribers to her free integrative magazine, The Stacks. And we'll make sure that we link all this if you're a provider that listens. She's known for helping clinicians see their own potential, inspiring curiosity, vulnerability, and mind-changing, and for giving physicians the push they need to become the best at what they do. As a retired ND, she's paving the way for clinicians to love their work, career, and even critical appraisal of research. So thank you for joining me on this episode.
Oh my gosh, thanks for having me. Yeah, I'm excited to chat about all of these things. It's funny when we're making that big long list of things we could talk about. It's really like the hormonal discussion is really endless. So hopefully we can cover a lot of ground today.
Yeah, so I like to kind of start by having you tell people, like, I guess, where did you start in medicine? How did you progress through medicine? Where are you now? Like, what do you do today? Just so that people know kind of, who's talking to them.
For sure. Yeah. And it's funny listening to you describe some of those pieces. I feel like you did a great job of trying to make what I call critical appraisal sound interesting. So my background and skill set is really in critical appraisal, which is kind of the analysis of research. It's almost the research of research. When I say this, people understand it a little better. I say, not every study that is published belongs in medicine. Right? Not every study that gets published should change the way we practice. And what critical appraisal does is helps us contextualize research as it's published to understand what should change the way that we practice medicine. And what do we kind of put on a shelf and say, okay, that's interesting. We need more evidence or more information, or that study wasn't done very well. We're just going to put that one in the trash because it maybe shouldn't change the way we think about anything. That's what a critical appraisal job actually is helping us take research and decide what belongs in practice. So my background started there. That's my training from an undergraduate perspective. That was at McMaster University in Hamilton. And after I finished my ND program, I actually went back to McMaster and taught for 15 years. And this is where people say, you don't look old enough to have been a professor. For 15 years, I taught research in integrative medicine and research in clinical nutrition. So helping undergraduate students, pre-med students, understand how to make decisions in nutrition and integrative medicine using literature. So that was my background. I then realized that my own profession really lacked the support that needed to be able to make these great decisions in practice every day. If you're a conventionally trained doctor, you have endless resources. If the antibiotic we're giving for UTIs changes, it doesn't take very long for those updates to be made and for every doctor to know, right? We have systems in place and we have standards of care. In integrative medicine, we don't have that like repository of information or standards. So each individual practitioner is left to find that information on their own, which means that they have all this work to do outside of seeing patients. But it also means that we're having physicians make those decisions one by one, rather than us having a more consensus-based approach to how we treat things. And my deep desire is that we start to develop a consensus on how we prescribe in functional medicine and integrative medicine, so that practitioners can just show up and do amazing things with their patients from a coaching and behavior change perspective, but maybe the answer of all the things that we do starts to sound more similar. It frustrates me, or it makes me mad when patients could go to two different functional doctors and get two different answers when one of them is well researched and the other one isn't. That has always frustrated me. So I wanted doctors to have access to the same level of resource that we have in conventional care.
Yeah, I think that's a really good point. I talk to a lot of people on this podcast, and I think one of the hangups with traditional medicine and what doctors will tell you is like a lot of them are scared because when we're in school, it's very like black and white, right? It's like you have this, then you must have, like they like to put people in boxes and compartmentalize things. And when you get into the real world, that's not the real world. And so that's one way that we set doctors up for failure, is that in the real world, people don't present with A, B, C, and you do A, B, and C and they get better. But the other way we set doctors up for failure is, if they actually do want to use their brain and think outside the box and look at somebody from a holistic standpoint, it's like they're scared. Like whenever I kind of got into functional medicine, right? It's like you put your toe into like this big, vast ocean and it's like, what am I doing? And so having a resource for providers and for patients as well, where they can go to and say, is this well studied? What does the literature say? I think would be very beneficial and might help change the trajectory of medicine, because you have all these people that are most people that go into medicine do it to help people. I truly believe in my heart there are not a bunch of people out there being doctors trying to be, facetious and trying to not make people better. The problem is they do what they're taught. Sometimes it's not always the standard of care or the best. And then when, again, you don't fit in that box, they just don't know what to do. The Hippocratic Oath is first do no harm, right? And so some people are paralyzed. They have this like analysis paralysis of doing anything. And I think that's one of the biggest problems that we have in healthcare currently. So I think this is a great way to fix that, right?
Yeah, I totally agree. And it's interesting. A lot of the systems we have in conventional medicine are really, they kind of have a stronghold on the way we deliver medicine, right? We get frustrated with, well, I went in with this and I left with a piece of paper, right? But your interaction with your doctor was maybe 7 or 9 minutes, and all you can get in that time is a prescription. I hope that we see, as things evolve, that provider time and provider coaching and behavior change. I want integrative practitioners to be like behavior change specialists, because that's really the missing piece in medicine, is the provider time, and then how providers help individuals actually execute the plan. Because even if we just give them a prescription, and even if that is the right answer, the vast majority of them never fill it, and then they don't take it properly, and then they don't finish it. So even in that very conventionally minded system, we have a gap in execution because we don't focus on behavior change and support and time. So, I think there's so much opportunity here for us to help clinicians understand what their role is in diagnostics, delivery of care, execution of care, and build a much deeper relationship between clinicians and patients when we focus on things from that more functional medicine approach, because it honors all of the parts about medicine that we're currently not able to honor in the conventional system.
Yeah, and I think also having a good resource or basis of studies to give patients, because, I have patients who come to me all the time, and, I don't force them to come. I don't do a lot of advertising. They come to me, and they'll say, well, they have a meeting with me. I tell them, this is what I want to do. Let's focus on your gut. Let's try to do things to get you off those SSRIs. I don't want you taking PPIs. Let's fix your gut. I really don't want you taking that statin because you don't need it. You've never had a heart attack, and, you've already got a thyroid issue. And so I'll give them these list of things that, like, this is my goal for you, after we discuss nutrition and we discuss movement and we discuss sleep and we discuss stress and we discuss sunlight. And then they come back 2 months later and they're like, well, I saw my primary care doctor and they said that everything that you said is crazy, crazy, and that all the literature says otherwise. And I'm like, well, maybe the literature that they read from 20 years ago. And there is literature out there to support what I'm saying, right? There's literature to show that statins actually cause breast cancer. There's literature to show that statins cause thyroid issues and glucose issues. And there's literature to tell you that if you actually looked at the literature from 20 years ago, statins, yes, they do help in secondary prevention, but not primary prevention. And there's not a single study in women ever with statins. And so it's just like, there's this huge disconnect, right, in what the study actually says and what it doesn't say, but then also in just this like holistic approach as well. A lot of these studies, like statin studies, they're looking at one thing, right? One outcome, but they're not looking at that big picture, which is like, what is that statin doing to your thyroid? What is it doing to your bone health? What is it doing to your insulin? They're focusing on one thing. And so I think that's part of the issue, is like, we need better information like this for patients so that they can look at it, and doctors as well, right? I truly in my heart don't think that people put, doctors put people on medications to harm them, right? They're doing what they think is right. But the problem is, like you said, a lot of these studies are made for maybe one reason, and we don't look at somebody as a whole. And so that's where I think we have to change things for people to get better.
Yeah, and it's interesting that you brought that statin example, because I'm very pro statin. So I think this is a really great piece to dialogue on, because it showcases how difficult clinical decision making actually is, and how many things actually have to go into that, we'll say that proverbial Venn diagram of how we make a decision for patients. I think where we sometimes can fall into a trap around clinical decision making is being able to, as doctors, contextualize what a benefit is and what a risk is when it comes to adding an intervention. And what my goal is, or what I would like for clinicians, is for them to have a resource that's helped with that, where we're able to, saying all things equal, right? How do we make a good decision for a patient that actually meets what their needs are? If we want to use that statin example, we have really great literature that, lowering LDL, we'll say by any means, right? Whether it's a statin or whether it's through, nutrition, does decrease the risk of cardiovascular disease and death from cardiovascular disease by like a relatively large magnitude. What we want for clinicians is for them to know that and know those numbers, and then for us to be able to contextualize that against those potential risks. So if we take the number one health and lifespan risk factor for North Americans, which is cardiovascular disease, and say we can change that by 25% with an intervention, and there is a 0.1% chance that it will cause breast cancer, or I don't know the statistics on that, to be perfectly honest. I think it's relatively low. How do we help patients make that decision, right? Because those are just numbers. It's actually not really even the physician's job to decide if numbers are important. It's actually the patient's job to decide that. So if we say, well, we can lower your risk of a heart attack by X percent, and the risk is X percent, do either of those numbers matter to you? And a clinical decision is that you're going to have one patient whose best friend died of breast cancer, and she's like, I will not do anything, even if it increases my risk by a micron. That's a personal decision that she's trying to make with that data. Whereas from a doctor perspective, if we were going to bet on a horse and we said, well, this horse has a guaranteed chance of winning and this horse has never won a race in their life, we would pick the winning horse, right? So it's clinical decisions are very, very challenging. But where we've struggled in integrative medicine is we've never had a spot that was able to lay everything out as equal. So if you went to a conference that was very pro IV therapy, you'd leave thinking it solved every problem. And then if you went to a pharmaceutical conference, you would leave thinking that solved every problem. We've never had a really great resource that said, okay, everything being equal, what do we pick, right? And that's really what I want for clinicians is that they feel like it's a menu of options that are available to patients, and that we deeply understand the statistics on whether or not we choose one over another or how we would choose one over another. But it's not easy, right? Because a patient who loves running is going to get a different prescription than a patient who loves yoga. And that is when we need to empower clinicians to be able to take an unbiased approach to be able to support their patients where they're at.
Yeah, and to your point, with the statins. So if your LDL is extremely high, that's one thing. If it's marginally high and your lipoprotein A is low, and you do exercise, or you could work on your diet, you already have thyroid issues. So yes, to your point, it's like helping people figure out the literature, but then also being able to figure out what side effects those things could have, and then how they could impact that patient as well. Does that make sense?
Totally. Yeah. And that's where we love that risk application, right? To make sure that, and probably, and this is why we can't get statins in a vending machine, right? Is that you hopefully are having a great conversation with someone before you get any prescription. But it should be individualized based on your personal risk score. And that's why we want clinicians to be able to have that info in front of them so they can help you make a good decision. I always say, let's just bet on the winning horse. But if we don't know which one's going to win, then it really is a shot in the dark. And we want clinicians to have access to the knowledge that helps them know which horse is more likely to win this race.
Yeah, that's true. And then also being able to find reasonable studies about side effects, different things like that as well. Because I also think sometimes with studies, they'll say, oh, well, here are some common side effects. But then maybe after the study is published, or you've seen as a clinician 2,000 people, on medications, knowing that, okay, well, this medication can also cause this, or, knowing how your gut affects hormones and just different things like that. I think being able to go and look at some of these things that a lot of people don't study, right? So like traditional medicine doesn't study, how does your microbiome affected by hormones, or how is your microbiome affected by dyes, or how is your microbiome affected by processed foods? Being able to just go somewhere and find actual good studies about this and information about this, I think is very helpful too, because in traditional medicine, we don't learn anything about that, right? So like when I was in medical school, I learned nothing about nutrition. Like there was no nutrition class, zero, which is really sad, because like to your point, and I tell my patients this, if you've come to me and you haven't even started to dive into nutrition and exercise and sunlight and stress, then you're and sleep, you're sort of wasting your money coming to me, right? Because we got to get some of those foundational basic things down before we start trying to throw all this other stuff at you. So I think just having all that available for providers would be very helpful, because that's not something they teach us in school.
100%. Yeah, nutrition is such a great example because it's such a complicated thing to study even. And so it's hard to imagine that we release doctors into the world with no knowledge on a particular area in health, although that is what happens.
We do.
Also not the skills to read about it. Nutrition requires a very unique way of reading about it in research. And when we release doctors into the world without that knowledge, they'll never get caught up, right? They don't know why we need to lean on observational research and nutrition occasionally versus interventional research, where when we study pharmaceuticals, we can give everybody a drug and they weren't taking the drug before the study started. Everybody's eating food. So it's harder to study food and nutrition because the person's baseline nutrition impacts the research. The person's behavior tendencies impact the research. But yet doctors don't graduate with that inherent ability to read nutritional research. And so it can be quite frustrating for patients because they can feel like nutrition knowledge that as it's being published isn't making it into medicine. And that's actually true, right? We don't have a good way of nutrition making it into medical practices besides doctors taking a personal interest in it and spending time on it. So yeah, it's definitely a challenge.
So speaking of nutrition, then talk to me about this. So you obviously are like a guru of nutritional literature and research. And so I would say one of the biggest things that bothers me on social media and whenever I think about nutrition and what patients come to me with are these like extremist people who say like, this is the only way, right? Keto is the only way, carnivore is the only way, plant is the only way. So talk to me about that. Are any of these studies that people quote valid? Like, what are your thoughts on keto versus carnivore versus plant-based versus Mediterranean? Like, what does the literature actually say?
Yeah, I joke. I mean, carnivore is the never diet, right? Like, I always want to, I'm like, can I see these people's skin in 5 years when they haven't eaten any antioxidants? This is what I would like to know. So where we get hung up, and this is kind of across the board with integrative medicine, is we quite often will cite biological plausibility as the basis for why we think something is true. And what we mean by biological plausibility, where it's like, well, on paper, this might happen. And you'll get a lot of, comments like, well, this has fructose in it, and fructose raises X, Y, and Z, and X, Y, and Z leads to macular degeneration. But what we don't have is any evidence that people eating those foods actually causes macular degeneration. We've narrowed our understanding of human beings to like arrows and potential. And that's where there's this often a big gap where we'll say something like, we'll villainize something like a particular molecule that's in plants, like lectins or something, and then say, well, because biochemically, this particular ingredient has the potential to cause inflammation, therefore we should not eat vegetables. So that's like camp A. When we look at the actual literature, like the people who live the longest eat the most vegetables. The people who have the best cardiovascular outcomes eat vegetables. The people who live the longest with cancer eat vegetables. Like pick a condition, right? When we look at the actual human beings, and the irony is in evidence-based or in integrative medicine, we'll say, treat the whole person. And yet we've decreased our understanding of nutrition down to a couple of arrows when we have all of this literature over here about what happens when we look at the whole person. If we feed the whole person the Mediterranean diet, they live longer. But for some reason over here, we've decided this one arrow on a piece of paper should dictate how humans eat. So I think those extremist diets have they manipulate the conversation around evidence to meet their narrative. I don't think they're going into reading research. And this is where, like, as a researcher, every single time you read a paper, you have to look at your own bias. You have to be like, am I reading this in a tone, right? When you get an email from a friend and you think that friend's mad at you, you immediately read the email like they're mad, right? And you're like, I knew it. I knew she was going to cancel. No, like, right? You're reading it with a lens because you already think she's mad. Mm-hmm. When we read studies, we have to be so careful that we're not reading it in that frame of mind. And yet, when we look at the real promoters of these extremist diets, they like conveniently will ignore thousands of studies that say the opposite and then cherry pick one paper and one arrow and one molecule and use that to build their entire argument. So, and obviously I have quite a bit to say about this, but that's where the big problems are with those extremist diets. Now, what will happen is you'll say, but my friend Betsy, right? But my friend so-and-so, she ate carnivore and she feels the best she's ever felt. Mm-hmm. We've really missed the boat when we're looking at like how one human being feels after eating one diet for 2 weeks, when we would never read a drug trial and accept that, right? If we're like, gave it to one person for 2 weeks and they felt amazing, we'd be like, I'd like to see more research. Mm-hmm. And yet, when we talk about nutrition, the person in the cubicle beside us starts eating something weird for lunch, and we're like, maybe I should do that. Mm-hmm. So the body of literature is so pro-Mediterranean that it's really hard not to ignore at this point.
Yeah, I would agree with that. And I've been very open about this, and I get a lot of hate. I am not a very extremist when it comes to diets. I think that is ridiculous. I'm extremist with sugar and processed foods. Like, I don't think that you need sugar or processed foods to live. Your body can make fructose and sugar through things like fruits and natural things that were put on this planet. But in general, the people who are toting this are, if you look at them, them, not to be mean, but it's usually these people that are like, probably have some body dysmorphia anyways, right? Like these like 0% body fat. But it's just, it doesn't make sense, right? Like, yes, maybe you lose a lot of weight. Yes, it could help you lose some weight. Yeah. But again, it's not like, I have patients who come to me and they need to lose 100 pounds and they say, I want to go keto. Are you okay with me going keto? I'm always going to meet you where you are. So my answer is going to be, if you feel like keto is what you need to do to lose some of this weight, then yes, I would rather you do a keto diet and lose 100 pounds. And then we put you on a sustainable lifetime diet where you do get nutrients and the things that you need, like the Mediterranean diet, right? So I'm not saying never do I think that this is usable, but I do think that staying on a restrictive diet like that, no matter what it is, as long as it's not well balanced for a very prolonged period of time, is a bad idea. And I think that literature supports that. And to your point, like, yes, I think that you need to eat vegetables, you need to eat fruits, you need to eat some whole grains, you need to eat meat, you need to eat fish, and so it's just, I think that is interesting. And to your point, I have people who say that to me all the time. Like, I saw a lady yesterday who said, well, I'm 30 pounds overweight and my friend hasn't eaten a single carb in 3 years and she feels the best she's ever felt. So that's what I'm going to do. And then as she kept talking, she was telling me, but my friend also complains that she has to eat less and less every year or she gains weight. And she also has headaches every now and then. And her hair started falling out, but she looks amazing. Like, okay, well, that's because she's highly malnourished because she's eating 800 calories a day and it's all meat. Like, she needs antioxidants, right? And so, yes, to your point, I think that just sometimes literature can be difficult to interpret, but you're saying that you still feel like from the massive body of literature, the Mediterranean diet is still the best way to go.
Totally. And what I would love to see is, and it's coming, is the discussion around, I'm going to say, like, culturally adapted Mediterranean diets. And so we know when people eat that theme of the Mediterranean diet, but perhaps keep to their cultural roots, they have the same outcomes, or we think they're having the same outcomes. So if you don't identify as someone who's going to use olives, or you don't identify as that being your dominant cultural diet to eat Mediterranean, but you get to the nuts and bolts of it, which is healthy oils, fruits and vegetables, whole grains, right? Like low saturated fat, low fat dairy. Like, if you can get to the bones of the med diet and do it in a cuisine that meets your culture, we know that your compliance will be better, right? And really, when we're talking about nutrition, we're talking about compliance over a long window of time. So even if the keto diet helps someone get into calorie restriction, which is how it works for weight loss, there's no other magical way that it's helping. Is that the lifetime nutrition plan for this person? Is that a long-term sustainable plan for this person? Because you could get the same outcome with a different diet, despite what people think. You can get the same outcome with a different diet, and maybe that other diet actually is easier for you or is closer to your cultural cuisine that you could eat with consistency. That's actually going to have the better outcomes long term. So it's interesting, but we often lose that forest for the trees discussion around nutrition because we've distilled it down to a chemical reaction that we think is bad. But when we put that same diet in a big human, nothing happens, right? And so we have to be quite mindful of how we think about that kind of literature and the way that we, talk about some of those biological processes, because even if autophagy, right, or whatever it is that we're after from a biochemical perspective is happening in a test tube, we don't have a heck of a lot of evidence that that's happening in a human being. So we have to be quite mindful of how emphatic we are about nutrition change when we don't have clinical outcomes to support it.
Yeah, and I think nutrition is hard too, because there's so many things with nutrition that is just so personal, right? Like, people use food differently. Like, some people, it's a very big staple to like their family, their culture. Some people don't care. And so it's different. Like, people look at food so differently. Like, my husband and I, it's very interesting. When we got married, I realized I've always just eaten to like have fuel, right? Like, that's just, I don't know. I was busy. I was in med school. I was like, I never really thought about food other than like, well, I needed to fuel my body. I needed to think. I needed to be able to do what I need to do, right? I guess I wasn't a part of a family where we like sat and had these big meals and like made a big deal about it. I meet my husband and marry him, and it's like, he wants to have dinner every night and sit and talk. And it's like this whole ritual and it's this whole thing. And I'm just like, what is that? You know what I mean? It's just people, it kind of opened my eyes to the fact that like, he doesn't necessarily live to eat, but like, that's a big thing for him. He wants to sit down and have a meal once a day and have some community and like talk about it. And it's interesting. So everyone looks at nutrition differently too. And so, if you took that away from him, he would not do well. Right. So if you gave somebody like that a diet where it's like, this is all that you're going to eat and it's very small meals and you have to eat at these certain times and, it's like a quick thing, that's not going to be sustainable for somebody who is used to this like cultural family once a day, like big meal. Right. So then you just have to figure out how to fit that into their lifestyle. And I think that's a problem with a lot of the diets and things out there is like, you want to put everyone in these boxes, just like traditional medicine, but it doesn't work like that with everyone, right?
Mm-hmm. Yeah, such a good point.
Yeah. So tell me about protein and then we'll transition from diet. But a lot of people ask about the actual literature on protein. And when I say protein, I want to know how much you really should eat to sustain and keep muscle mass, especially as women get older. But then also, is it really okay to get 100% of your protein from plant and none of it from animal or vice versa?
Mm-hmm. That's a great question. And I think to preface that conversation, I will say that the vast majority of people, population-wise, don't meet their protein targets. So sometimes when we start to jump in this like sort of functional medicine or integrative medicine space and talk about, particular dietary needs or what have you, someone listening may be on the upper echelon of protein intake already, right? And they're trying to figure out how to optimize their nutrition versus this first part of the conversation is like, from a basic health perspective, most people on average are not hitting that general target. So when I say these numbers, don't let that land the wrong way for those people who are listening, who are like, I already do that, right? Because I'm not talking to you, I'm talking to everybody else for a second. But we know that in general, we need a more than 1.2 grams per kilo per day. And what our goals are with that amount is to prevent age-related muscle loss or sarcopenia. We know that, and there's great large-scale trials now looking at the different quartiles of protein intake. So are you below 0.8? Are you 0.8 to 1, 0.2? Are you 1.2 or above? I guess those are trials, not quartiles. The people in the 1.2 category, so if you eat more than 1.2, they have less age-related muscle loss. They have they fare much better from a lean tissue perspective than people below that number. Now, the curiosity, and here's where the art of practice comes in, is most people have a lot of dietary variability from day to day. And so when we pick the bare ass minimum as the number, for the majority of people, they're going to spend some days above that number and some days below that number. I would say from a clinical practice perspective, we might want to hedge closer towards 1.5 grams per kilo per day, because then if people have this variation and day to day, and I didn't have any meat today, and I forgot to have my smoothie tomorrow, kind of thing, it actually allows for inter-day variability in protein intake, and yet we still hit this average of 1.2 grams per day. There are pockets of people that benefit from more. So people that are high intensity athletes and who do a lot of endurance-based training may benefit from a higher number because it's harder to fuel that person. They generally need more focused fueling. They also could burn some of their tissue through high intensity, long endurance exercise. And so do we get up to 1.7 grams per kilo in that population? Maybe, right? But in general, when we're talking population wide, we want about 1.2 to 1.7 grams per kilo per day. If you eat more than that, you just have to certainly ask yourself the question, it's at what cost? Because when we get up there, it's taking up space in your diet that maybe other food now is missing. So we start to lose some of the benefits above a certain number where more is not better. And now protein's taking up a lot of space in your diet, and maybe now you're not eating an orange because you're eating more protein. That's where the curiosity of that sort of replacement effect comes in nutrition, where if we really push pedal to the metal on one nutrient, you are removing other things from the diet. And so we have to be curious about that above that 1.7 grams, that may be at a cost, right, to other nutrients that we still want you to have in your diet.
Yeah. And so for listeners, when she says 1.2 grams per kg, I did some math. That's about 0.55 grams per pound. So it's about a little over half your body weight in pounds. And then 1.5 kgs is about 0.68, so about 0.7. So if you're looking to like optimize 0.7 grams per pound, because most of my listeners are probably going to be pounds people. So that's not quite the whole 1 gram per pound that a lot of people quote. And I would say, to your point, and this is usually ideal body weight, correct? This is not current body weight, or is it?
Yeah.
It's ideal. Yeah. So, I have a lot of people who tell me this, like when they're trying to lose weight, if I have 100 and, for easy math, 200-pound woman, and they're wanting to lose weight and to be 150 pounds, you're looking at having them need to be having 100, 110 grams of protein to be optimal. If you try to push that to 150 grams and make them have another 40 grams of protein a day, they're not going to be able to get their berries in or some of their carbs in. And then a lot of times what women will do, because this is what we do, we'll eat our protein and we'll eat our fats because we like them, and we won't get our carbs. And if you aren't getting an extra 60 or 70 carbs that you need a day for energy, about 2 weeks into that weight loss program, when you're exercising, your body's going to go, nope, I'm done. I don't have the energy to do this. And so to your point, when you're eating extra protein, sometimes at the expenditure of good carbohydrates, which is what women do, because again, we're in this bad mindset, then you crash and burn, right?
Mm-hmm. Yeah. And it's that sustainability piece though, right? Like often when we just blindly tell people to increase their protein, they may inadvertently also increase their saturated fat because their sources of protein are high saturated fat. And that's not just an endless, that's not a goal. So to your point and question about plant-based protein is that, more and more we have evidence to support that plant-based protein performs as well as meat-based proteins for maintaining muscle mass, which maybe 10 years ago, we might've said something a little different, this is one thing I love about research is we get to change our mind freely. We actually get quite rewarded for changing our mind in research, is that we do have great evidence that, soy-based proteins, etc., do preserve muscle mass, especially when they are paired with resistance training. And I think just to back up 1 sec, I want to make sure I don't misspeak. Maintaining muscle mass has more to do with resistance training than it does your protein intake. We can actually out-exercise your low-protein diet a little bit, but the absolute benefit is the protein plus resistance training. That's actually how we combat age-related muscle loss, not protein alone. And if we just do protein alone and nobody exercises with resistance, they still lose their muscle mass. Maybe not quite as quickly as if they didn't eat any protein, but they're not combating that age-related loss just by being protein sufficient. You have to pair it with resistance training. So when we look at soy or vegetarian-based proteins paired with exercise, they perform just about as well as whey protein. And so if that, really makes you happy to include more plant-based protein, and I think we've got lots of good reasons to do that, then we now have more evidence that it is just as good for your muscles as animal-based protein, which is music to my ears, right? I would definitely 10 years ago have told patients, if you have to choose animal-based protein. Now we can certainly be way more free with our choices from a protein perspective to hit those numbers.
Yeah, because some people, I will say, they just don't digest protein as well as what they tell me. And to your point, there are some really good, I actually prefer plant-based protein when I'm making shakes. So there's some good pea proteins. There's a lot of people using egg whites for protein, pumpkin seeds. I have a protein I use with pumpkin seeds, egg whites, and pea protein. It's wonderful. It's so good. And sometimes I mix a little bit of dairy-free or some Greek yogurt, dairy-free, or I'll do a lactose-free Greek yogurt with it. It's a wonderful source of protein. You get 30 grams of protein, you're so full, but you don't feel that bloated, when you eat a big burger or a big steak. And so that's actually what I eat a lot of times before bed. So I'm a protein fanatic. My patients know this. That's the one thing I track is my protein, because when we get busy. Yesterday, I'm sad to say this, at 7 p.m. last night, I look at my phone, I had only had 53 grams of protein, and I was like, this is a problem. So then that's whenever I have shakes, like before bed. And it's one of those things that you can have. I had a huge plant protein shake last night before bed with a little bit of Greek yogurt. So I ended up having like almost 40 grams of protein about an hour before bed, which I don't love to do, but I wasn't miserable because it doesn't like set on your stomach the same, at least for me, like it'll still digest. And like my REM sleep was fine. My HRV wasn't super high. And so it gives people options, right?
Totally. Yeah. Yeah. And there's certainly I'm not an environmental expert. I'll be the first to say there's certainly a wider conversation about the environmental impacts of, animal-based protein versus vegetarian-based protein that I'm super open to watching, right? Us to understand that a little better. I think having a variety in protein sources is really great for on all accounts.
So you mentioned that age-related muscle mass loss. I want to talk to you about that too. So age-related muscle mass loss, I think, is a huge topic. It's an valued topic. And I think you hit on some things. So I think that we lose muscle as we age because we don't resistant train enough. We don't get enough protein. And then I think there's a hormonal component to it as well. Would you agree with that statement?
Totally. Yeah, we do know that we have lean tissue loss after menopause. And in that 4-year window around the last menstrual period, there does seem to be a more rapid loss of lean tissue. So that's happening. We also, our muscle cells change with age. They become less, they're less able to repair. They are slower to repair. The same amount of exercise maybe causes more tissue trauma, and it's slower to repair. We also will see that the impacts of obesity also influence muscle capability of regeneration and function. So there's that concept of sarcopenic obesity, meaning you're overweight but under-muscled, or have visceral adiposity or weight gain and you're under-muscled. That hormonal soup is really not very positive for muscle mass. And we have what's called a little bit of protein resistance as we age. So we need a little bit more protein per pound of body weight as we get older to not have this catabolic process from happening. We're less likely to build muscle tissue with age because our muscle cells are not as adept at growing with age. You can watch a 21-year-old man eat grilled cheese and seem to grow muscle, and then as women age, it's feels like things are kind of stacked against you. But it does take us some mindfulness around protein intake, exercise, and then us being mindful of that metabolic consequence of menopause and the impact that obesity has on muscle loss as well.
So talk to me about the gaps in standards of care as far as menopause and hormones in general. What are some of the biggest ones you see? I mean, patients are so confused about, is estrogen really harmful? Should I be on estrogen? As a woman, can I take testosterone? I think there's just so many gaps in standard of care, even between physicians, right? You'll have different physicians saying different things. And I think, unfortunately, that Gen X population, a little bit older than I am, those women that are right now, perimenopause and transitioning to menopause, you guys have just gotten the brunt of this because of the WHI and all of this. And so I feel or maybe even a little bit older, maybe the women that are almost 60 now, unfortunately, and maybe into their, 60s, a lot of them were not allowed to take hormones, right? Everyone was scared of hormones. And so I feel there's a lot of gaps in knowledge and just in standards of care as far as hormones go. What are some of the top 3 that you see?
Yeah, that's a huge question. It's funny because I was still thinking about the muscle loss piece. And for me, some of those challenges in standard of care. So what does standard of care mean, right? If we back up for a second, it's standard of care is if we delivered these rules to the population, they would be a net positive. That's what standard of care really means, that at a public health level, if we did these things, it would be net positive. That's why we have screening programs. That's why we have, right? It's net positive. If we put everybody through these rules, on average, everybody does better. Now, we can certainly, even if I just say that, you can probably go, yeah, but there's got to be one person who's not served by that, right? There's got to be one person who, if we do step 1 to 10, they don't get better. Or they only needed step 1 to 3 and they're better. And we don't need to force them through the other steps. We can see that if we put 100 people through a 10-step standard of care, Some of them don't get better. Some of them need more time. Some of them need something different. Some of them have a coexisting medical condition that made it harder for them to do the steps. Like, we can see that. But what standard of care really is, it's helping the most amount of people have good. And so generally they are correct, right? Where the challenges come in is when they're not being delivered, right? So for menopause, the standard of care has been HRT. It's not like it just arrived in the standard of care. It has been the gold standard for certain aspects of menopausal care, like hot flashes, for example. It's just that it wasn't being done. So one of our big challenges is when standard of care don't happen. That's a problem. We also have a challenge is that standard of care don't think about the practicality of medicine being delivered. So there was this really wicked study of studies. It actually was a study of guidelines, which as a researcher, that's my favorite kind of work. It's like when someone does a study on all the guidelines, that's just music to my ears. And what they learned is whether they looked at NAMS, whether they looked at the NICE guidelines, the guidelines were accurate, but nowhere in the guidelines did they tell doctors how to do it, right? Like, well, when do you have this person back? When do you ask them about their sleep? How are we going to deliver this when you only have 7 minutes? There were no instructions on the deliverability of the standard of care. The standard of care was correct, but the system that we're trying to deliver it in doesn't have the capacity to do it. And that's where people end up frustrated, because the answer is the answer. The standard of care is correct, but they got 9 minutes with their doctor, and their doctor never said when to go back. And they never got referred to a dietitian, and they never even mentioned that they should do strength training. And so the standard of care said all those things. It said, give them HRT, tell them to come back in 6 weeks, tell them to see someone to help them with their weightlifting. The standard of care said that, but the delivery of it was impossible for the clinician because they had 7 minutes and no support. So that's a really important piece, is that the guidelines have been, by and large, pretty accurate over the last little while, that the execution of it has not happened very well because the system that we're in, medicine-wise, was hoping you had strep throat, and this was a very easy answer. But menopause is a very difficult answer. It needs time. It needs behavior change. It needs screening, right? It needs prevention. And none of that is wired into conventional care. So now we have this very frustrated population saying, no one's giving me what I should get. And it's like, well, the standard of care was correct. It's that we didn't have a system in place to give it to you. So that's one part, right? That sometimes we just don't do it because it's not possible in our current setup. And this is what drives people to see an integrative doctor, is they're like, can someone talk to me for an hour, please? Like, that's the thing they get the most benefit from is provider time. And if that integrative doctor just literally follows the playbook of standard of care, that patient is so much better cared for because they got time. The other side of it is that because standard of care is talking about the masses, sometimes one person who's going through that needs a different lens, or we've learned enough about preventative medicine that we need to intervene earlier, or we need to take a slightly different approach, but it's not written in stone in the standard of care. Sarcopenia is an awesome example. The standard of care is if you don't suspect muscle loss in your patient, you don't have to do anything, but check again the next time you see them. So that's the current standard of care for sarcopenia. Check. And if you don't think they have muscle loss, you don't have to do anything. See them next time. See them in a year. Whereas for functional medicine, we would say, okay, well, at this moment, I don't think they have muscle loss, but I better check on their exercise, nutrition, hormones, right? Like, we would take a very different approach. Even if the person was very well, we wouldn't just watch and wait. We wouldn't say, like, check you later. Hopefully nothing happens between now and the next time I see you. We would actually do something. And that's a gap in the standard of care for sarcopenia, is prevention. Prevention is nowhere in the discussion, actually. And so I've written my own version where I'm like, yeah. The standard of care says, like, send them home. In my opinion, right? We need to have a really big conversation about prevention, because we can prevent this, and because the next time you see them, they will have muscle loss. So why wouldn't we talk about protein today, right? So that's the other side of standard of care, is that there's often these points where the literature actually suggests something just a touch different, And following the playbook doesn't actually get us the best outcome. It gives the most people benefit, but it doesn't give us the best outcome. And that's where we would maybe have some room for improvement.
I like that. You said the standard of care, like, I think that's why functional medicine is so validating and so important, because standard of care is, like you said, you run all these people through it, and for the most part that may work. But if you're somebody who's listening to this and you are frustrated, then you probably do need this different approach, or this different lens, or a different way for it to be done. And unfortunately, even I did a fellowship, so I did an extra 2 years of just diabetes, hormone, metabolism, thyroid, right? In that extra 2 years, nobody sat me down, gave me a playbook and said, here, Cassie, this is how you talk to somebody about nutrition. This is how you talk to somebody about, none of that. And that's a very, I think, important point that I've never really thought about. We train doctors, here's a disease process. Here are the reasons it's happening. Here are the ways to treat it. But we never train them as to how do you have that discussion in this amount of time? When do you have them come back? How do you help them fix their mindset? And what do you do when that doesn't work, right? When that just one thing that you're supposed to do doesn't work, what do you do? And that's where I think, unfortunately, pharmaceutical companies have come in and have said, oh, well, we have an answer for that. And it's really easy. You just have to write something, or we have. And so it's pretty interesting. You said that, I had all these light bulbs going off thinking about, like, my training, right? You learn all these things, and the pharmaceutical companies come in even while you're training in med school, and they'll start teaching you, oh, well, if a person has this, you can do this. If a person had, and so I think that's probably where we end up with these patients on 10 medications, and doctors don't know what to do because they have 7 minutes. They don't have an actual playbook as to how they're supposed to fix this, but they remember this conversation of, well, you can write this and it helps the symptoms. And so you do that, and then there the patient goes. So that's pretty sad, but you kind of just brought it all together for me. So it is true. Like, when you look at guidelines, like when you look at thyroid cancer guidelines, I remember coming out of fellowship. If anyone's ever read the thyroid cancer guidelines, they're 421 pages, American Thyroid Association guidelines. They were published in 2015 last time. I think we have a new episode, like a new guideline coming out this year. But if you read them, because I read all 421 pages of these guidelines, because they were supposed to be amazing for the change of thyroid cancer treatment and hypothyroidism. And if you read every single one of them, there really isn't a place in there where they talk about how to implement it and really when to recheck. There will be times where they're like, oh, well, you should check this yearly, or you should check this based on, how likely they are to recur. But, like, what does that mean? There is no, like, I feel like at the end of a guideline, there should literally be visit 1, these are the labs you do, visit 2, these are the labs that you do, or these are the things you discuss, or this is when you repeat the labs based on your results. Like, I think that would be very helpful in medicine. So
Totally. And we fall into that, just, it's a great question, is if we asked doctors who even practice functional medicine and said, how long does a patient need to take fish oil before it impacts their muscle mass if they have sarcopenia? We wouldn't know, right? We might even not even be able to list fish oil as an answer. And it is one of the answers, especially if patients are protein deficient or on bed rest. But we don't have this great guideline of, like, they take it and they take it for 6 months. They take it and we don't expect an outcome for 6 months. So one of my goals at Confident Clinician is that I want the clinician to have that answer. So how confident would you be sitting down with a patient and saying, I'm going to put you on fish oil. It's going to take us 6 months difference, right? That's such a different way of prescribing than saying fish oil helps your muscles, right? Like, it's a very different way, and it elevates our care. It elevates our the perception of what's possible with integrative medicine. If we were willing to have that level of data to support what we do, it would help us integrate so much better into conventional medicine and impact so many more people if we held ourselves to that standard. Because the pharmaceutical companies have done an amazing job of being like, take the SSRI, check it 2 weeks, maximum benefit at 12. Like, they've done an amazing education job for how long people need to be on medication. And yet we haven't had that same luxury in integrative medicine to say, like, how long do you take the fish oil before your omega-3 index goes up? Like, nobody seems to know the answer to that. It's in the literature, but it's not accessible. It's not something that you could just grab. And that's really my goal with TCC, is that we've created that resource for people to give them that level of confidence in prescribing.
Yeah. And so same thing with, like, when you're talking about menopause and hormones. So Is there, I mean, I was just thinking about this when you look at the guidelines, HRT is the guideline for menopause. Like, yes, you do need to do hormone replacement therapy when you go through menopause, but is there anywhere that talks about, how long you do it, when you recheck labs? Like, I was just thinking about that. I don't know that I've ever read that. Like, is there somewhere that says, hey, these are the levels you're shooting for. If you don't get to them, this is what you do. This is how you titrate. I mean, I know they're not in the thyroid guidelines, so that's pretty interesting. And so then you're just leaving doctors out there to kind of figure it out on their own. And that's probably why you have a lot of doctors who say, well, I don't know, you should stop hormones at this point, or, you just take the lowest dose, and they don't really know what to say, right? They have no clue.
No, and especially since we've come at that discussion with a little bit of a lowest dose for the least amount of time, kind of fear-based conversation, it takes a lot of convincing to convince a doctor to change the way they practice, just because even the way we basically used to read HRT instructions the way we read our angry email from our girlfriend, right? Where we're like, is she mad? To bring it back to that, we read the guide, like we would almost read those guidelines like, does this cause cancer? And if you read it with that lens, you're going to go, okay, you know what? Let's not take too much. Let's not do this for too long. And that influenced prescribing practices. And now we're having to undo that and be like, whoa. Like, why do we want to accelerate their bone loss at this moment in time? Like, we don't need to come off of those hormones. I think that's a really important point, right? That like the way that guidelines get written often ends up being a way that influences how physicians practice. And it may not allow us to actually practice in the best way possible because we've not been able to think about it through that like preventative medicine lens, or maybe there's a couple of lines missing in that guideline that tells you how to do it. And so it's leaving up too much interpretation for the physician. And that just leaves frustrated patients, because if you have a doctor who just has never been a great prescriber of hormones, it's hard for them to change because they're just reading this playbook and they don't have a lot of support for how to do it.
So, but you are saying from the literature, just to clarify, that when people enter menopause or are perimenopausal, there are definite benefits of taking hormone replacement therapy, and that includes estrogen therapy, correct? The literature says that. Those are the standards of care.
Oh, yeah, 100%. And actually, your best case scenario is probably estrogen alone if you have had a hysterectomy. That's where most of our positive data comes, is actually in estrogen therapy alone. Most people require progesterone or progestin to be prescribed with it. But yes, the estrogen therapy is like very pro, and whether you do or don't need progesterone to go along with it. And I'm not saying progesterone doesn't have its own unique positive benefits. I'm saying from the overall literature, the group of people that perform the best are the people that are on estrogen alone because they've not needed a progesterone or progestin. But yes, like the evidence is very clear that it's positive.
Yeah. So the competent clinician that you have, all of these things are like, you've put this together in a database where providers can look this up and say, I can, if I have a patient, I can type in, how long will it take for fish oil to benefit someone's muscle mass? And that would just come up with an answer, almost like up to date. Is that how this program works?
Yeah, it does. So we've built it similar to many other databases, but with more deeper benefits to other databases. And so for us, we want to meet clinicians in the moment when they need the answer to the question, because the patient's sitting across from them, right? Like their patient's right there and they want to know, do I pick Boswellia or do I pick curcumin for this osteoarthritis? And they can actually ask our system, and we have like a AI-driven smart search that only listens to our content. So it's not reading Joe Smith's article or blog on curcumin that's somewhere on the interwebs. It's only using our vetted information. And so you can get the answer like right in the moment. And we also have clinical practice guidelines. And so this question of how and when do we do things and what's the most important, that's available like at a glance. So if you're with a patient and you need the information the moment you need it, it's right there. But we also deliver 90% of our content in a live presentation the first time. And the reason we wanted to do that is because like mastery on a topic involves dialogue. You need context. So reading me saying, give your patient fish oil for their muscles is totally different than listening to me talk about it for 8 minutes. And so all of our content actually has a more in-depth version that clinicians can go and listen to. And our goal with that is that we have more confident prescribers. We have prescribers who feel like they have a seat at the table in medicine because we've shown them the literature and how we came up with our answers. But it also lets them leverage their membership. So if you want to show up more confidently online talking about muscle mass, there's nothing better than going and listening to my 3-hour lecture on it, and then you can give your own presentation on it. So we want to create an army of confident, integrative, evidence-based practitioners that are influencing in their community in a really positive way. So our deep dive content gives that level of confidence so that you could go do your own presentation or give your own podcast and have the knowledge you need to really like elevate the level of information that we put out there as an industry.
Where were you whenever I needed to write papers in college? Right? Like kids have it so easy nowadays. I'm like, man, I could have went to college and did anything. Like, remember when you had to go to the library and like look all this stuff up? Remember the Dewey Decimal System? I remember that. Yeah, that's awesome. That's awesome, Dr. Jordan. Okay. So I think that all this was a great conversation, great topic. You know, this could honestly change the trajectory of medicine if we could get doctors on board with this. And especially like if you're a provider listening to this and you've thought about, I have a lot of you who reach out to me like, I'm thinking about functional medicine. It's so scary. I don't know where to go get the right information. How do I learn? This sounds like a good way to start, right? This is a great way to like dip your toe in, look stuff up, and just know, like, and I've told people this, it's scary. Like I was the most traditional type A in the box endocrinologist until 2020 that you would have ever met. Like I was going to go off of every guideline. I was that person. And then I started learning this functional medicine space, and it is scary at first, but I surrounded myself with a lot of people who were very knowledgeable. I just tried to learn things. And I was pretty honest with my patients too. When I started doing it, like, hey, I don't know, but let's try this. I'll help you figure it out. Like I'm never going to do anything to harm you, but I'm pretty honest with my patients, and with new peptides and just all the new stuff that comes out, we have this array of things that we can offer people. And I will tell them like, I feel this is safe because of X, Y, and Z. This is what I don't know. If you want to try it, let's do it. And if not, we don't have to. But this seems like something that would be very good for a lot of providers that listen to this as well. Do you guys do stuff with peptide therapy too?
I mean, we've definitely covered, and we have a great obesity medicine event coming in the spring of 2025. And we're doing a big deep dive, and it's actually a revisit because we've definitely covered the GLP agonists previous to this year. But looking at specifically the appetite based peptides. The peptide stuff is really interesting because again, what I would love, right? And I'm trying to be unbiased around how I feel about literature, is that I would love some human intervention data for some of these unique peptides that we're looking at, and it's coming, right? It's coming, we're watching it, but we have this, promise and this due diligence to deliver things at a certain level of evidence. We, like you made that example, if you sit down with a patient and you're like, look, we've tried everything. Mm-hmm. If patients aren't well and they've tried everything, it changes the way we feel about evidence. Because what that means is that what we have and what we know in this moment is not working for them. What happens more often is that people haven't tried the things that we should try first, right? And we jump to the new and novel therapeutic before trying the med diet or some other strategy. But there's definitely moments, and even we'll do this in conventional care. If someone's like a non-responder, eventually we have to get creative, right? And that's kind of that art side of medicine, but not before we haven't tried the tried, tested, and true things that work in most people. But sometimes we do have to get creative. But I love the peptide stuff that is coming out, and I'm curious about how that's going to influence medicine over the next 5 or 10 years. I'm hopeful that we see more human interventional data on it. So it will satisfy that part of my research brain that wants to see those clinical outcomes.
Awesome. So I have 3 questions I end every podcast with. Don't overthink them. Very simple, but people love this. So the first question is, what is one food that is most beneficial and why?
I'm going to say whey protein powder. And just the research that's positive for this just is endless, whether it's looking at postprandial glucose or looking at muscle mass or looking at appetite control or it's endless, the benefits of whey protein powder. So that would be my answer.
Okay. What is one thing that anyone can do that will improve their health that's 100% free?
Well, I think walking is an underrated tool. People can do it at almost all fitness levels. And I mean, and acknowledging that if walking is not accessible to you, then it is whatever that version of walking would be for you based on your physical limitations. But that very like low impact, but you can do it for a long time exercise is really underutilized, especially in our very sedentary world. That's one thing that's free that I think if more people spent time outside, especially walking, that it would improve everyone's health by and large.
And then the last question, what is one thing you wish that you would have known about your health 15 to 20 years ago that you would have done differently? And it can be like research. So maybe there's new research. You would have done something differently.
Ooh, I think, and I've talked about this on my podcast before as well, that I never really understood how deeply rooted the genetics acne were. And, as a young person who had acne, and then as a young adult who had adult acne, I spent a lot of time believing that there was something wrong with me, or there was some food I needed to eliminate, or there was some magical skin cream that I had yet to invest in, without recognizing that acne is actually a medical condition that we manage. We may not cure in all individuals. And when I learned that, it really shifted my mindset to be around like long-term thoughts about my skin and health versus, we can think about skin the same way we think about weight management. It's like, what's the latest and greatest? What's the newest? And I really spent a long time chasing ineffective skin solutions and also blaming myself for my chronic skin issues when the majority of adult acne does have a deep genetic basis, and we need to manage it, maybe not cure it. And I think that's a really important piece that I learned in my own health journey.
Okay. I like all of those answers. So Dr. Jordan Robertson, thank you for being on the Back to the Basics podcast. We're going to link all of your stuff, so your social and all the stuff about the Confident Clinician, we will link in the show notes. If you're listening to this and you think somebody that you know or love would benefit from this information, please make sure that you share it. If you are a provider that's listening to this, you definitely need to think about this. If you haven't heard of the Confident Clinician, I would highly recommend that you check this out. Look at this, especially if you're somebody who is frustrated. I know there's a lot of providers that listen to me that are frustrated with the state of healthcare right now. And so this is a way that you could start learning things and feel more confident talking to patients about things that might actually help them and things that we didn't learn about in school. So it's not your fault, because I did an endocrinology fellowship and I didn't learn about nutrition. But this would be a good way for you to feel more confident, not only helping your patients, but maybe helping yourself. So I would highly recommend that you check this out and make sure that you share, like this, follow us, and then tune in next week for another episode. I hope you found this week's episode of Hormones, Metabolism, and You helpful. Please, please, please do me a favor. And if you enjoyed this episode, share it with someone. I know you can think of at least one person that needs to hear this information. There was some valuable information, not only about hormones, but cholesterol and lots of other things. So please share this. Make sure you're following us wherever you get your podcast episodes. Please leave us a review. Make sure you're following me on social media. Let me know who you want me to interview, what you want to learn about. I have a lot of exciting stuff coming with social media. Our gut app is available now. We have a lot of nutrition information and some gut webinars that are coming out as well. So make sure you're following us. And lastly, if you are interested in being a patient, Modern Endocrine has a license in 39 states now. We do virtual visits. If you live in Oklahoma, we can do virtual visits, or you can come to our state-of-the-art clinic. And we have an amazing functional nutritionist who helps us from a nutrition and lifestyle coaching perspective as well. Thank you again for joining us this week, for trying to take some time out of your busy life to learn about how to better your health. And we look forward to chatting with you next week. Have a great week. The information presented, including any materials discussed, referenced, or linked within this podcast, are for general educational purposes only, not the practice of medicine. No doctor-patient relationship is formed from you listening to this podcast or utilizing any of the information provided. I am a doctor, but I am not talking to you as your doctor. The information provided is not intended to diagnose or treat health problems, or take the place of the professional medical care provided by your doctor. If you are experiencing any health problems, including problems you believe have been touched upon in any respect within this podcast, you should consult your doctor about the problems without delay. You may ask your doctor whether he or she believes the information I have provided would be helpful to you, but you should still consult your doctor immediately and follow his or her medical advice as your treating physician. I'm just here to provide you basic knowledge about the issues we discuss so you are more aware of them and can better discuss them with your doctor. That's why we call it Back to the Basics. Join me on the next episode as we continue our journey.